later. And now I have the pleasure to introduce our next panel. It's another policy panel, this time focused on legislative policy. We got to hear about Medicaid agency policy and programs and reimbursement. Now we're going to be talking about what state legislatures and Congress can do to support maternal mental health and mental health more broadly. To help us unpack all that's happening at the state and federal level, I would love to introduce now a colleague, Jim Bialik from the Perigee Fund. Jim is a public policy expert and political tactician. I've seen it already in the works and love being in the weeds with you, Jim. With 15 years of experience in legislative advocacy, community capacity building, and policy development for organizations like the nonprofit 0 to 3. He was involved in the passage of 3 federal laws, 31 state laws, and a dozen of substantive regulatory changes. He's testified before the U.S. House of Representatives twice, as at least one other member of our panel has as well, and now serves as a senior program officer for policy and advocacy at the Perigee Fund, a philanthropy focused on ending intergenerational trauma, which we talked about a lot today, through the power of early relationships by resourcing Black, Indigenous, and people of color organizations and women-led organizations, including ours, thank you, Jim and Perigee, while focusing on the needs of prenatal to age 3 families. We're grateful that you're here, Jim, and really happy to have you moderating today's session. And I'm actually going to join you all as a panelist on the main stage for this session. Welcome, everyone. Over to you, Jim.
Thanks. Thank you so much. And I am thrilled to have the opportunity not only to be a part of this event, which I loved being just being in the audience at last year, and then now doing that as well, leading up to this panel. So it has been a real treat so far to hear just the excitement that there is around maternal mental health, and also just the wide array of approaches that are not only new, but being expanded or being empowered as a part of the work that you all are doing. And I think that having this panel is particularly timely because we all know that a lot of the real innovations that we've seen in treatment and coverage, especially coverage on maternal mental health, comes in almost an innovation of how best to manage, handle, or get around existing law or regulation, so that something that we know works can be meaningfully applied to moms and babies. And so with this panel, I think it's an opportunity for us to talk about what is going on in the policy world, both at the state and federal level, but also, excitingly, talk about what the opportunities are to bring lessons learned, the good outcomes, and also now this a lot more data that we've had than we previously had in the past, and put it in front of the right people so that we can change policy, change legislation, and quite honestly, shape the environment. So I want to make sure to introduce our panel here. So if you all can give me a quick introduction of yourselves, I'll go just around the horn here. Mary, do you want to kick us off?
Sure. I'm Mary Giliberti. I'm the Chief Public Policy Officer for Mental Health America. Mental Health America is a national organization with over 140 affiliates around the country focused on prevention, early intervention, and recovery.
Excellent. Thank you. Julie?
Hi, everyone. My name is Julie Garner, and I'm with Sage Therapeutics. I look after government affairs and public policy, both federal and state level. I just wanted to quickly share a startling statistic that I saw in a JAMA article earlier this month, in that the US has a 2 to 3-fold greater maternal mortality than any other high-income country. And so that is why we're here today, to really talk about the urgent need to medicalize PPD like any other disease, so that we can address the gaps so that there is better diagnosis and treatment options. So thank you.
Excellent. Thank you. And then Lauren.
Hi, I'm Lauren Finke. I'm the Senior Director of Policy at the Kennedy Forum. We were founded by Patrick Kennedy when he left Congress, and he's the author of the Federal Parity Act. And so that was really, the basis of a lot of the work we do is ensuring compliance with federal parity laws. And we've done a lot, of that work at the state level too. And so where that intersects with coverage and access issues for maternal mental health coverage, that's really the sweet spot for us here today.
Fantastic. And Joy, we know you. So moving us forward here, I really want to make sure that we're able to use this time we have together. You can hear from the panel that we have a really diverse group coming at it from a number of different angles. But I want to kick off with talking about some themes that we've heard throughout the forum so far, but that we really do know are being carried into the conversation about policy and advocacy. One of the top ones really has to be access. We saw it very prominently in, I think, the word cloud after every session we've had so far. And an issue that has been coming up more and more in a number of different settings in a number of different ways has been prior authorization. And Lauren, I know that you've been doing some work in this space and would love to get your thoughts and feelings around quite honestly what's going on and how it's impacting this space so much right now.
Yeah, I mean, I think of prior authorization under this larger umbrella of utilization management tools and things that, health plans and benefit managers require of providers in order to sort of obtain information so that people can get care. I think oftentimes what we see is because of the nature of these tools that they can often result in interrupted care and delayed care and a lot of uncertainty for providers and patients. We frequently hear from providers about the increased administrative burden that often will lead to providers either not taking insurance coverage for some of these things in mental health and substance use disorder care in particular, but then also, people just giving up trying to find that care or paying for that care out of pocket. So, these are very important pieces for us. I think there's a lot of very clear solutions that we can take at both state level and the federal level. And the federal government's done quite a bit on this too, through our parity rules and CMS through their recent prior authorization rule as well. So we've got some good things on the horizon. I think that while there is a place for some of these utilization management tools, considering when and how those policies are crafted and making sure that they're under, clinical validity, like that is the underlying piece for that we are ensuring continuity of care and transparency. I think all of those things are really important, areas to make sure that we're focusing a lot of those practices around. And I'll just quote real quick, the AMA has some data on this. They've done a lot of good work on prior authorization, but while their data shows 93% of providers reporting care delays because of prior authorization, 82% reporting treatment abandonment because of prior authorization, 24% saying that it led, or providers saying that the delay in care led to a hospitalization of their patient. Those are like really astounding percentages to me. Every time I read them, they feel really important, especially when we think about, with the grounding of what this looks like for mothers and families too, of what we have a critical area of care, and really making sure that we're opening up access during those critical times, I think is really important, and part of why the prior authorization conversation is so important for getting care for these populations.
Yeah, it's super interesting to hear, especially with the AMA statistics. Because I think about when I hear prior authorization, I think about it in on like the pharmacology side, right? Where, prior authorization around access to medications has been something that has been touted, as an adherence tool, largely because of I mean, understanding the cost of of taking medications, of buying the medications. And so one of those things that, it's a better understanding upfront. It can be done where it's part of the relationship between the provider and the patient, instead of, going to the pharmacy and walking up and not knowing the price and then saying, oh my God, I can't do this. And while there may have been another, therapeutic alternative, you're out of the doctor's office at that point, so you're not able to have that conversation. So having it in the room was so important. And I think what you're talking about, and I think is fascinating, is almost like the other side of that coin, right? Where you're talking about, we're now saying prior authorization for a number of different conditions and use cases that may not have the same follow-up steps. So what prior authorization means in the care setting may be different than what the outcome or what the desired outcome in the process is for the patient, like what their next step might be and what's actually covered. Is that what you're finding? Is that what you've been hearing as the major barrier is the diversity of patients that are needing the prior authorization, and who it's working for and who it's not really working for?
Yeah, I mean, the AMA percentages that I just shared were, across the board, so including medical surgical too. I think what we know from, talking to patients and consumers of the system and providers in the mental health and substance use disorder space in particular is that those barriers can sometimes be even worse across the board. And I know I mentioned a few things like making sure that utilization review determinations are made off of clinical models and standards, not sort of criteria that's not aligned with those things. You had mentioned a few things like having to go through authorization processes like over and over again. So making sure that authorizations are valid for a full course of treatment, prohibiting retroactive denials once things are granted. Those are all things that we see a lot in the mental health space too. And not that they don't exist elsewhere, but a lot of these things are really exacerbated from when you get into the mental health care space. And as Julie mentioned in her opening, making sure that we're opening up those those areas and being very clear about what the solutions are, I think is really important, and making sure that we have transparency and in what we're expecting in like a perfect world of access and care for prior authorization. We do have really good solutions, and I think we've seen some good reform in prior auth over the last few years, actually even just the last year from the government too. So I'll list just a few things that I think are important parts that most of them fit directly under the prior auth umbrella, but some of them fit just generally under utilization management practices. But I think you'll see why I view them as related. So, tying the medical necessity standards to the clinical standards of care, and oftentimes that's the nonprofit clinical association criteria. I think that, can move mountains, especially in the mental health space. Making sure that benefit determinations are made by clinicians that are licensed and in the same specialty as the cases that they're deciding, right? So someone who has an expertise in postpartum care, that could go a long way when they're reviewing those cases. Making sure that authorizations, I already said them, but valid for a full course of treatment. Honoring a patient's prior authorizations when they've switched plans, so you have continuity of care. And then there's other, areas like gold carding and things like that I think can be really helpful for this space.
And as we're getting into those solutions, I want to talk about, I guess, the entire role of the care continuum and all the ways that people touch it. So, Julie, I know that prior auth has been a tentpole of a lot of policy in the pharma world, especially around adherence and other tools. That how are you seeing it from your side around confirmation around care and ensuring that you're getting the right drug to the right person?
Well, I think that the patient-provider relationship, as you mentioned, Jim, is the North Star, and nothing should interfere with that. That said, appropriate patients also need to be identified. And as I mentioned in my opening, time is critical. Those stats are real. I think we'll hear from all of the panelists, and certainly in other sessions today too, that's not the only fact point. We have other data sets that are suggesting that our maternal mental health outcomes are not great. And so any barriers to access really need to be limited. And I think that this is a place where science and policy can really play an important role in helping to drive healthcare innovation for patients, and new standards or treatments rather can really elevate standards of care, and public policies can really accelerate that potential impact. So I think as Joy will mention, we're looking at policies across the country right now that would really limit and prohibit step therapy. There was just a bill introduced in Louisiana that would prohibit step therapy for all newly approved PPD products. We know that with PPD, there's a really limited amount of time. So ensuring that the patient is getting on the right medicine that their provider has prescribed for them is really essential, because again, that timing is really, really critical.
And so, Mary, I know that you guys are steeped in the work that is happening at the federal level on this, and I was wondering, can you tell us about some of the legislation that's out there? I know the Support Act comes to mind as an opportunity to address several different issues, I think, with a similar policy lever. How does this, how is this address the issue relative to maternal mental health? And I know substance disorder is another big part of this as well.
That's right. The Support Act has a number of provisions around substance use, but of particular interest to, I think, this audience is the program for residential treatment for pregnant and postpartum women. That program is at the Substance Abuse and Mental Health Services Administration, and the bill would reauthorize it for 5 years at $38.9 million a year, which is an increase. But of course, Joy and I were talking about the data and the need to keep moving these programs up and getting more resources. We know how hard it is to find beds, particularly when you have children. So it's really difficult for women to find these kind of services. And we know that substance use is increasing, that the maternal death rate also, the major drivers are overdose and suicide. So it's the #1 driver for maternal death, according to CDC. So when you look at that data that we were talking about earlier, really a need for these programs like the Support Act programs. Some other things that MHA is keeping an eye on, we really support peer support services in that bill, reauthorizing, actually initially authorizing the Office on Recovery at SAMHSA. So it's an important bill. So where is it? It's gone through the House, it's gone through the Senate committees. We are waiting to see when we can get it onto the floors and through the process to get enacted. There was some hope that it might ride on the appropriations bills. We're waiting on that bill for fiscal year 24, like right as we speak, like tonight or tomorrow, we're going to see that bill. The latest intel is that Support Act is not on it. Of course, we won't know till we see the language, but that's the intel. What does that mean? It means we're going to have to fight during this year. We got to get it done this calendar year. There are going to be other healthcare bills, things that are need to get addressed, and we got to get Support Act on that so we get it through the process, because it's really important. So we'll be looking for advocacy opportunities to move that bill forward and get it done over the finish line.
Excellent. That's fantastic to hear. And I've heard as of this morning that the meetings on where things stand with the budget are starting to interfere with the first of the March Madness games. So staff has been really interested in getting this done as fast as they can, so they can focus on other things. Joy, I want to talk to you because you not only have quite a bit of experience, passing bills on the federal level, but also looking at what undergirds all of this good work. We've been talking about maternal mental health in so many different ways, which require so many different systems. And even when those systems play really well together, they need so many different people to be a part of that process. And, to have a policy conversation where workforce doesn't come up is, certainly ignoring a major issue in the room. And so, with the some of these can be addressed through the Moms Matter Act, but we're going to have some challenges with that this year. And the Momnibus bills don't have quite the energy behind them that they had in previous Congress. But I do want to get your opinion on what are some of the federal opportunities there, and how should we be thinking about workforce when it comes to federal policy, not just for what can move right now, but how we should be thinking about the 119th Congress as well.
Yeah, and I just want to thank again the panel yesterday that addressed workforce solutions. And when we think about maternal mental health, we're thinking about access to things like certified peer support specialists, doulas. Many states are starting to certify doulas, and also community health workers, which we're taking a closer look at in California with some new reimbursement levers that are in place to expand obstetric care provider ability to screen, provide brief intervention and care coordination through CHWs. As you mentioned, Jim, the Moms Matter Act is the maternal mental health bill that most notably addresses workforce. But I think it's nice for the audience to understand that when we talk about solutions at a federal level, we're really talking about, generally about funding, grants to states or grants to programs to support state-based interventions and pilot programs. So that's all helpful and good. And we certainly need federal funds to support increasing the number of BIPOC providers, which the Moms Matter Act addresses. And I just would quickly highlight that, where the rubber meets the road is in state health policy. And I do think there's some opportunity in state health policy to address workforce network adequacy perhaps through frameworks like state-based mental health parity laws, although we are all anxiously awaiting the Department of Labor's and HHS's new federal regulations. And so maybe that won't be necessary, but I just make the case that network adequacy is, I think, where we need to start. And then reporting on coverage policies is something that we've reported on relative to access to the new postpartum depression drug. How are insurers sharing the providers, the workforce that they cover and how they cover? How are these workforces reimbursed, for example? And also monitoring the number of those workforce professionals in their network. That can be done through state-based policy. And I'll give you a quick example. In Arizona, the first Medicaid agency that's taking a look at monitoring the number of perinatal mental health certified providers in their network. That's being done voluntarily, not through legislation, but we know many state legislators want to do something here. And so they can give a nod to Medicaid agencies to make this a priority.
So, I think that really highlights another leg of the stool here, which is discussing the issue of payment. Mary, I know that there, not just on the legislative side, but there's a ton of regulation around here, particularly as it pertains to Medicaid and CMS, and transparency around some of the payment levels and pricing as well, or payment levels, I should say. And so can you give us a bit of an update there on some of the access rules that are coming, as well as, I know there's some proposals before Congress as well on some reimbursement rate issues as well.
Sure. And I think when you think about maternal mental health, we have specific policies that target that, but then there are these larger systemic issues, the payment issues. And I'm very excited about Medicaid access rules. I'm a real policy wonk to be excited about that, but I am. And the reason is that it was proposed last spring and it's at Office of Management and Budget right now. So we should expect it soon, like April, May-ish. And it requires, as you mentioned, transparency in rates. And we know that providers are underpaid. It also requires secret shopper audits, which will really tell us a lot more about these networks. What are the wait times people are experiencing? Are these networks real instead of ghosts, as we see in Medicaid in particular? So we're excited to see that regulation get finalized because we think it'll make a big difference in access. What we're also seeing at the federal level is bills that are proposing to bump up the Medicaid match, the federal contribution to Medicaid. It's going to be tough in an election year to move that forward because of the cost, but we're going to be fighting for that. And we're seeing states, Joy mentioned the states move forward with rate increases. Like Kaiser Family Foundation found that 32 states moved forward in 2023 with at least some rate increase in fee-for-service Medicaid around behavioral health, and 33 will do so in 24. So there's a lot of advocacy at the state and federal level. With the elections, we're just watching what's called often entitlement reform that sometimes is code for cutting Medicaid and particularly block grants, which I call a zombie policy. We kill it and it rises from the dead. So we just keep watching those policies because we do not want to see Medicaid cut in any way. It needs to be expanded and robustly resourced.
It makes a lot of sense. And we're running low on time, but I do want to talk about one more piece of this, which is, I guess, that is really describing the changing style of care. And Julie, this goes to you. That Sage has developed a postpartum depression specific drug, and I know that that from an approach perspective, that's new, which means that you're rewiring a lot of what it takes to get from bench to bedside here. So I was wondering if you could tell us a little bit about access and how coverage, and it seems like you hit all the pieces that we talked about here.
No, it's thank you. Generally, obviously, we're at a very early days. Zurzuvae was approved back in August of last year and commercially available in December of last year. So we are still very much in the early days, but I would say generally and at a high level, it's trending really well. Of course, we are supporting and encouraging access policies to support moms to be able to have access to the product. Public policy does play a really important role in creating better outcomes for moms and for families. And we need policies that promote parity for physical and mental health, that address barriers and foster equitable access. Gaps many patients can face include, as I mentioned before, step therapy, but also inconsistent screening practices and, of course, access challenges. And I think that someone had mentioned earlier that the spotlight is really shining right now on maternal mental health. And so I think that this can be a call to action for us to work together to create a better ecosystem. And that's through education and early intervention and public policies that really equitize maternal mental health.
Well, I think we're coming up on time here, so I want to turn it back over to Joy, but I absolutely want to thank our panel. I know there's going to be a ton of questions from this crowd. There are a lot of implementers, wonks, and we're all in good company here, so that are going to be interested in following up. So I want to thank you all very much, and thank Joy for putting together such a great event, and I'll pass it back to you.
Great. Thank you so much, Jim. And I think I'm going to go ahead and ask all of you to help contribute to an upcoming blog post around federal and state legislative policy and the opportunities. I know, Mary, you're following the Support Act. We definitely want to follow that closely. Lauren, you and the federal mental health parity regulations, not legislation, but regulation that really matters and may impact state policy. So, and of course, the coverage of Zurzuvae is at the top of one of our priority lists as well, to make sure that there's ready access. So appreciate all three of you. We'll be in touch about how we can keep the field up to date on all the moving parts. And Jim, thank you for moderating. We are going to share Rio Holiday's illustration of this session. Let's see what you have, Rio, if we can spotlight that illustration and what we've captured here. Access, we knew that would be a leading word, and then on the horizon, prior authorization, parity rules, billing, the Support Act. You got it all, and billing just was highlighted there, right on cue.